Perfect. So this is kind of then if you missed that, this is the structure of this current presentation. So just to start, I'm not going to go into detail about recognition or management of shock, but suffice it to say, it's a state of organ hyperperfusion related to cardiac dysfunction. Mortality typically in hospital has been between 40 and 50%. It's kind of common in trial data over the past 25 years, a little bit higher in the acute MI cohorts, but hovering just under 50%. Hasn't gotten a lot better in 25 years. And certainly there has not been a lot in terms of evidence-based management. We kind of do a lot of the same that we did 25 years ago. Holger Thiel, who works in Germany, Holger Thiel is kind of probably the most prolific and well-known cardiogenic shock trialist in the world. And he's put together some really good review articles. And one of them is this article in EHJ looking at evidence to date for acute MI-related cardiogenic shock. So all of these blue columns here are trials that had been completed. Now, mind you, this is 5 years ago, 2019, and red columns are trials that are ongoing. But as many of you might know, out of all these trials, only one of them was positive. And again, I'm not really talking about what's happened over the past few years with devices and MCS, just medical therapy. And that was the shock trial in 1999. And we haven't had a new therapy that improves outcomes really since then. So this is the shock trial, as many of you likely know, before 1999. Essentially, we didn't know if revascularizing, for instance, non-STEMIs with cardiogenic shock was a good idea and if it improved outcomes. So they did this huge registry, the shock registry, as many of you may know. And then out of the huge shock registry with a couple thousand patients, they took 300, randomized them to early revascularization or medical therapy, which is lytics and balloon pumps, and revascularization improved outcomes. Their primary outcome, 30-day survival, significantly better in the revascularization group. And that's why we revascularize, non-STEMIs urgently that are hypoperfusing. And again, that's kind of the only thing that we have that improves outcomes since that year. I really like to figure this small meta-analysis organized by type of intervention. So again, this is 2019, so things have changed in the past 5 years. But starting at revascularization, we know that this is pretty much everything we knew in 2019 about how to manage shock. So definitely revascularization, we know that that's good. Culprit shock, many of you likely know that trial, and the interventionalists certainly know it. But randomizing patients with multivessel disease and acute MI, acute coronary syndrome related shock. We know if you do immediate multivessel PCI, they do worse in terms of soft outcomes, renal dysfunction, length in hospital. They also have increased mortality. So we revascularize the culprit lesion only, and if someone comes in shock with multivessel disease and a clear culprit plaque rupture. Vasopressors, data are a little bit less clear, but the SOAP2 trial, norepinephrine versus dopamine, all shock patients, sepsis, hemorrhagic, cardiogenic looped together. It was a negative trial. They did a pre-specified subgroup analysis of cardiogenic shock patients, which is positive. So norepinephrine improved mortality, increased survival, and then some other smaller CTs add to that. So that's another thing we think we know. We think norepinephrine is probably the first line vasopressor of choice for cardiogenic shock. The rest of things we're not so sure about. So the next on his list is inotropes, which I'm going to talk about, so I won't touch on that. But lots of cool ideas people had: nitric oxide synthase inhibitors, GP2B3A, hypothermia seem to be neutral. We know balloon pumps seem to not improve outcomes on a population level for routine use. Of course, it's a good summary, again, 5 years ago of everything that we know. So I'll start just talking a little bit about inotropes. And when I say inotropes, I actually mean inodilators. Some people think of epinephrine and norepinephrine as an inotrope, which they are, but because they increase afterload, they're very, very different than these medications. So of course, inodilators do two things. They decrease afterload and they increase contractility through a variety of mechanisms. And we have two of them in Canada, dobutamine and milrinone. Levosimendan is what they use in Europe, and levosimendan actually has all the evidence really right now for cardiogenic shock. But it's a calcium sensitizer, and it's not available in North America right now. So I won't speak too much about that medication, but I'll focus on what we have, which is dobutamine and milrinone, the two I know dilators. So DOREMI 1, I won't spend too much time on this trial. This came out of Ottawa. This was before my time, but it's with the group that I now work with. It's a very impressive pragmatic trial done in our center at the Heart Institute in Ottawa, comparing milrinone to dobutamine in kind of all comers with cardiogenic shock, all types of shock except for post-cardiotomy, which was in a different unit. It was actually a controversial trial. A lot of people were uncomfortable randomizing. There was this belief that milrinone was better than dobutamine, and it turns out, it was, as many of you know, it was a neutral trial. And when looking at these patients, the primary outcome in hospital death, cerebrovascular events, cardiac events, renal events, there's no difference between the two. There's also no difference in terms of mortality between the two. And there was also no difference in hemodynamic data in terms of the vasoactive inotropic score and renal function, lactate clearance. A lot of what we looked at was remarkably similar in both groups. So really, I'm quite convinced these two medications work the same, have the same outcomes when used on a routine basis on a population level. And of course, they're different medications. They have different mechanisms of action, and there are people that have strong beliefs about certain patient populations and how one might work better than the other in patients with certain comorbidities or certain clinical presentations. And that's totally fine. And people have different thoughts. I personally just use dobutamine now because it's cheaper and it costs less for the hospital, and I consider them to be the same. So that's why I choose dobutamine. But everyone has their own, specific personal beliefs about these two medications. There are a lot of very interesting sub papers that you may have missed, and I think they're worth mentioning. We did a number of them, but I just chose 4 to touch on briefly. The arrhythmic events subpaper was quite interesting. It was a simple concept. We looked at rates of VT and SVT and across the whole randomized cohort. And we found that VT and SVT, understandably, were associated with bad outcomes in our population. VT with mortality, both of them with cardiac arrest and increase in hospital stay. But the reason it's interesting is really there is this very strong, widely held belief that dobutamine, because the beta-adrenergic signaling is associated with increased risk of arrhythmias. And at least in our cohort, of course, when I go through these subgroup analysis, of course, there's always the caveat for each one that it's a post-hoc analysis and wasn't powered for this particular observation. And these are hypothesis generating, but it is interesting that the rate of arrhythmias were the same, numerically fewer in dobutamine and statistically the same across both groups. So I'm at least reassured by this that I'm not going to increase the risk of VT in a sick patient if I choose one over the other. I think it was an interesting question. This is one that I think is very interesting that my colleague Pietro led, that I helped him with, looking at the impact of recent beta blocker use. So we looked at everyone that received a beta blocker within 24 hours, including patients that were, I'm sure you've seen patients that are given a bunch of beta blockers and emerge and a precipitate shock. And then it would also include patients that are on a beta blocker at home for heart failure. They have decompensated heart failure. So anyone that's had a beta blocker within 24 hours, there was some concern that the beta adrenergic effect of dobutamine would be attenuated if the receptors are blocked, and it seemed to be the same. We looked at both hemodynamic and clinical outcomes. So the hemodynamics were the same in both groups, and the clinical outcomes, you didn't do better if you received milrinone despite being on a beta blocker. Now, that wasn't the most interesting thing. The most interesting thing is that people on beta blockers did much better, significantly better than people that were not on beta blockers. And that's that graph there in the middle. Survival and freedom from cardiac arrest or death and freedom from death in the first 48 hours was significantly less in the beta blocker group. and we've hypothesized about some of the reasons for that. But certainly, this does not mean that it's safe to give beta blockers to people in cardiogenic shock. I think we all know that would be unwise. But for whatever reason, this group of patients did better, whether it's representative of another protective factor or simply that it was truly protective. We don't know, obviously, without studying it in a different way, but it was just an interesting kind of signal that I wanted to share. So that's this. This was another subgroup analysis subpaper that I led, looking at mean arterial pressure and outcomes. And we essentially looked at patients that achieved an average mean arterial pressure 70 or greater, and then compared it to patients that could not. And not surprisingly at all, no one's surprised by this, of course, people that were able to achieve a MAP of 70 or greater in the first few hours did much better than people that did not. And the reason I show this is, I think we all agree that in this patient population, this was probably a marker of milder shock. So, if your MAP was higher than 70, you probably weren't on pressors, or if you were, it was a lower dose, and therefore your shock was less severe, and you were more likely to survive to discharge. Now, the reason I show it is I think it's just an extremely interesting question to answer and ask ourselves, what MAP should we be targeting? And this paper is hypothesis generating, of course. But this question of mean arterial pressure has been studied in the septic shock population. It's been studied in the post-cardiac arrest population as well. And it's never been studied in cardiogenic shock, which is a unique group of patients because, of course, coronary perfusion pressure is very important with sick hearts. And the thought is likely that increased mean arterial pressure might have higher coronary perfusion pressure, increased renal perfusion, which, all these patients, just all you need to do is decongest them as quickly as possible. And if you can kind of get someone to start peeing however you can, usually they'll do a bit better. And then, of course, it comes with the consequence of higher afterload and higher vasopressor dose, maybe increased risk of arrhythmia. So, yeah, that's the only reason I share this. It's just a very interesting question that I hope to answer one day. And if I don't, I hope someone else answers it the proper way. But we really have 65 is kind of just a random number that in this population that we're just extrapolating from other populations. Another sub-analysis that I led that looked at valvular dysfunction, which ties into some of the other things I'll be speaking about, but what is the impact of valvular dysfunction in this cohort? So we looked at patients with significant valvular disease, moderate to severe or greater stenosis or regurgitation based on our echo at the Heart Institute. And 40% of patients had significant valve disease, and they did significantly worse. So that's, again, not too surprising. It's just an important sort of target for intervention, and it leads into some of the other things that I'll talk about. But people with aortic stenosis in shock in this cohort did terribly. There were only 9 of them, but 2 of them survived, and 7 of them died in hospital. Mitral regurgitation, about greater than 50% of them did not survive to discharge, which is much less than the rest of the cohort. So these people are very sick, people with valve disease who go into shock. I know you guys have seen your fair share of those at St. Mike's, but they don't do well. So it's an interesting target for intervention. Now, I wasn't involved in this meta-analysis, but I just show this because with the Dormy data incorporated, the team did a network meta-analysis, just going over everything we knew at the time about inotropes, and it's published in the Canadian Journal of Anesthesia. And really, using this grade analysis for the network meta-analysis they did, the only thing they could say is that levosimendan is probably better than placebo. And we don't know much about anything else in terms of what's better, what's worse, what's harmful. So we can't say much about dobutamine or milrinone right now. So, and this ties into one of the criticisms that they got from Dormy 1, which is that we are comparing 2 unproven therapies to one another. We actually have no idea if they work. We only use inotropes or inodilators in cardiogenic shock because we think they help, and because it's really all we have to give. but we actually have no idea if they work. And we know all the data we have suggest harm, and that's data from the decompensated inpatient heart failure population. In the trials that have looked at inotropes in the heart failure population, decompensated heart failure, they all show harm. There isn't. I haven't come across evidence of benefit from use of inotropes in this population. So the data are quite sort of unanimous in increased mortality, increased hypotension, increased length of hospital stay, increased arrhythmias. We really don't know if it's any different for cardiogenic shock. And it's an interesting question to answer. So that's what led us to design the Dorney 2 trial, which I was lucky enough to be very involved in. And it takes people by surprise when they hear it for the first time. So some people at least, because we're so used to giving inotropes. That's like what we do. We give milrinone or DOB to people in shock. But there's a lot. I mean, I'm certainly convinced there's equipoise. If you look at the data, there is no data, and it might be harmful. So we were really keen to test this and make sure that what we were doing to patients was not harming them. So we designed this trial comparing inotropes to placebo in cardiogenic shock. And I'll tell you a little bit about it. So it's the initial resuscitation period, not the whole time they're in hospital, for Sky Class C or D shock. We're randomizing 346 participants to either the intervention group, which is the clinician's choice, milrinone or dobutamine, whatever they want, or placebo, and it's double-blinded. So the clinician would say, I would tell either the unblinded pharmacy or the unblinded nurse, they would say, I want you to mix milrinone if the patient's randomized to inotropes. But of course, they're blinded. We're including adults with Sky C or D cardiogenic shock, and we're excluding patients who are pregnant, out of hospital cardiac arrest, obviously recent use of inotropes. We don't want people already on milrinone to be randomized, and then patients with cardiac conditions that would make you kind of squirm and you kind of wouldn't want to use inotropes anyway, like HCM with obstruction or any kind of left ventricular flow tract obstruction, mitral stenosis, and aortic stenosis. Aortic stenosis is not as clear really, but because people are uncomfortable using inotropes for those to begin with, we just didn't include them. And the drug it's only 12 hours. So it's like we actually thought this 12-hour intervention period is critical. This is how you know if someone is not, if you haven't kind of steered the ship in the right direction after 12 hours, you're really worried about them. So it's this critical early resuscitation period that we're doing it. And so the study drug lasts either until the 12 hours are up or until an endpoint is reached, which I'll go over. And after that point, the patient stays blinded, the study drug gets thrown out, and they go open label. So the clinician can either put them on an inotrope, or they can not put them on an inotrope, or they could just continue the blinded study drug, which that's actually totally fine. We've seen some clinicians, if the patient's doing well with whatever they're on, be it inotrope or placebo, a lot of clinicians have not been going open label. They've just been continuing whatever they're getting. So that's another thing that they can do. And we're allowed to up titrate or down titrate the dose, similar to Dorney 1, and then following them till discharge. The primary outcome, composite of all-cause in-hospital death with these things that might happen within the 12 hours. So these are the safety nets. So if any of these 5 things happen in the 12 hours, the patient endpoints, and they go open label, but they stay blinded. So sustained hypotension, with high-dose vasopressors. If the dose of the vasopressor is going up, then that's, and of course, I should have said, obviously, vasopressors and inotropes, in my mind, are completely separate. They do opposite things, and vasopressors have nothing to do with this study. So obviously, use whatever you need to do to keep the mean arterial pressure appropriate, so the patient doesn't die, obviously, and as long as it's not milrinone or dobutamine. So if the vasopressor dose is going up, then that's an endpoint. If they don't clear their lactate at 6 hours, that's a really bad thing. We know that from lactate clearance studies. We did one lactate clearance studies from the Dorney 1 data, but there's lots of published data out there that if you're not clearing your lactate by 6 hours, that's really bad. 6 hours of resuscitation. So even if your lactate's 20 coming in and you don't get it to below 3.5 at 6 hours, you endpoint. But also if your lactate's 5 coming in and you don't get it below 3.5, of course, those are two different things, but both of them would endpoint. And then MCS, emergent electrical cardioversion, resuscitate cardiac arrest. Those would, as I said, would cause the study period to end, and the patient would not be on the study drug anymore unless the clinician wants them to continue. And we're about 54% of the way through. We've been randomizing we've been very happy with the progress. We have 3 sites now, and we're hoping to finish sometime next year, but we only have about 145 patients left to go. So that's DORMI 2. Happy to answer any questions at the end if anyone has any. And I'll move on now to the structural interventions in cardiogenic shock, which is the other area that I've been very interested in. So this is patients with valve dysfunction, and they're dying and they're in shock. And do we intervene? Do we not? And again, I know your team at St. Mike's has been leaders in this field for sure. So the TAVI literature there's new cohorts, big cohorts coming out. This is one of the first ones. It's 51 patients. Seems like it's feasible. So this is, again, patients in cardiogenic shock due to aortic stenosis, critical AS, who undergo salvage TAVI, and how they get into shock. If they've had AS for years, why do they suddenly go into shock? It's unclear, but I'm guessing it's a similar story. And a lot of them, something tips them over the edge, and they start spiraling. They can't recover, coming in shock. And I'm sure many of you know how hard it is to bring these people back from where they are. But TAVI, the cohorts show really low in-hospital mortality in these patients if you do TAVI. This is the biggest cohort that exists right now of this, and they actually had 5,000 patients in it. I'm not involved in any of this work, but 5,000 patients, very low in-hospital mortality, very similar to the non-cardiogenic shock population. If you look at that graph in the middle, the bottom one, the graphs separate out for the first 30 days. This is comparing TAVIs in shock to TAVIs not in shock. But if you get past the 30 days, they reset the survival curves. It's actually the same. So for these patients, they actually, in terms of the sort of registry data, they actually seem to do quite well if you can get them to TAVI. But it's more, logistics really a lot of the time. Like, can you do a TAVI in the middle of the night, or can you set them up for a TAVI first thing in the morning, because they don't have more than a couple days usually. But it's an interesting emerging field. It's never been tested in a randomized fashion, but it's very interesting. The next thing is, and that's just the survival curve, this is more what we've been involved in. This is an analysis that I was involved in, looking at 141 patients. There's a patient-level network meta-analysis of patients in shock with significant MR, 3+ or greater, who received emergency MitraClip. And again, this is, Dr. Pham and his colleagues have been doing this here. I've heard lots about the successes. And the mortality in this cohort is quite low, 15%. Higher mortality at 1 year, but 15% mortality. And what this patient-level network meta-analysis showed is that it was certainly seemed to be feasible. You can certainly you can get successful MitraClip or transcatheter edge-to-edge repair results in this population, bringing, with good results, very few patients with more than mild to moderate MR. And then the only actual cohorts we could compare were those, because we didn't have a control group, those that had successful clip, those that had failed clip, and obviously the successful clip did much better. But this study that we did led us to develop the protocol for the MINOS trial. This is another randomized trial that I've been involved in. Pietro De Santo, who's a interventionalist and intensivist. I think he might be the only one in Canada, interventional intensivist. He did the full PCI fellowship and the full ICU fellowship. So he's always this person that I'll never be anything like. But he's going to lead this trial in Ottawa, and we're randomizing 144 patients with shock to who have moderate to severe MR to MitraClip or medical therapy, MitraClip plus medical therapy or medical therapy alone. And this is something that St. Mike's is hopefully going to participate in the very near future. So we're including adults who have shock, moderate to severe MR, and eligible for MitraClip. There's a bunch of exclusion criteria that I won't go into detail about, but if, for instance, if you have primary MR, non-degenerative MR, and you are a surgical candidate, then you won't be included in the trial. It's for secondary MR, and if your MR is primary, then you have to be reviewed by a multidisciplinary team and deemed that you're not a surgical candidate, then you'll be included. And there's lots of good outcomes, composite outcome of all-cause in-hospital mortality, cardiac transplant, LVAD, discharge on palliative inotrope therapy, and then lots of secondary efficacy and safety outcomes as well. So that's a new trial, and as I said, this is something that St. Mike's is involved in. It's very early. We only have 8 patients randomized right now, and we hope to be done in the next few years. And it will kind of pave the way for structural interventions in this really sick population where it's kind of an unknown world. We know MitraClip works well for heart failure, stable heart failure patients, but we don't have any data to support its use necessarily in the shock population until now. And lastly, I just wanted to speak a little bit about outcomes, because it's another really interesting field of cardiogenic shock research. And it's something, looking at this data, this is something I actually use now to speak to families about. If you're a certain age and you have cardiogenic shock, survival is one thing, and long-term outcomes, quality of life, and discharge disposition is a whole other thing. It's really important for patients and their families to know when they decide whether or not they want to go to a critical care unit like a cardiac ICU with cardiogenic shock. So the Lotus program is actually a program not for cardiology, but for critical care, led by Shannon Fernando in Oshawa. It's inspired by a lot of people in Toronto, Margaret Herridge being one of the main ones. And it essentially uses ICES data and to look at outcomes in the critical illness population. They've published some amazing papers in JAMA, BMJ, intensive care medicine, looking at outcomes and post-survival of critical illness. So surviving is one thing. Everyone in these papers has already survived to discharge. It's more what comes after you survive. And again, that's something we really have to start talking to, or at least I have been trying to talk about to families about, because survival is just one aspect of what can happen after a frail person goes to the intensive care unit. So we really wanted to look at this in the cardiogenic shock population. So published a few papers now with this data. The first one was published in JACC, long-term outcomes of cardiogenic shock complicating myocardial infarction, specifically looking at the AMI population. There's 10,000 patients in this cohort, and we followed them over 10 years after their index admission. I'll just present very briefly the data because they're quite interesting. As you can see here in the table 1, a fairly typical, really bad MI cardiogenic shock population, mostly men, average median age of 70, and then all these typical spread of comorbidities that you see in these groups of patients. Most of them, 82% of them, came from home, independent. And then this is the really interesting graph that I love. It's very scary to look at, but it's fascinating. So 30% died in hospital, and that's pretty typical in the registry cohort data. The mortality is lower than the trial data, probably because of selection and who gets classified as having cardiogenic shock. So there were some milder forms of shock in this cohort. 30% died in hospital. But if you can look anywhere you want on this timeline, out of the patients that survived, less than half went home. 48% went home. But for instance, if you look at the 180-day mark at the bottom, the tiny blue, dark blue, and I don't have a pointer here, but they're still admitted. So that's microscopic. There's very few patients still admitted. The red is that the patients that have passed away. So that's a big chunk. At that point, it's about 40%. The black is readmitted and still readmitted. The purple is long-term rehab. There's not many long-term care. The orange is home with home care. And then at the top, which is like less than a quarter, is home without home care. So, I mean, at 6 months, 1 in 4 are home independent. which is a really striking observation and something that families need to know. That's all ages. So if you think about the elderly patient, the 80-year-old with shock, they really don't do well, and people need to know about this and be okay with it before they come to the ICU. This is the survival curve over 10 years, so drops below 40% near the 10-year mark, which is not a big surprise, just based on the average age and comorbidities of these patients. It's an interesting article. This is one I led, looking at cost and resource utilization in this unique cohort of patients with cardiogenic shock. There's been lots of papers like this in the general critical care world, not a lot in the critical care cardiology world. But what we saw was patients, so median 1-year costs in Ontario for a heart failure admission or an MI admission or ACS admissions around $10,000 US. And then cardiogenic shock complicating acute MI, if your lactate's high or you have some kind of marker on your code that marks you as having cardiogenic shock, your median cost is like 4 times that. And those that died in hospital had lower median costs, $17,000. Those that survived, $45,000. But the important thing about this is there's this huge heterogeneity among the patients that did survive. So there's these huge cost users, the lowest home time quartile patients, the patients that were at home the least after discharge, almost $80,000. And again, it's awkward to talk about money when we're talking about humans and human lives and people's family members, but it's just where we're putting resources is kind of the important thing. And really, what this tells me is that we really need to not only think about survival when we're looking after these patients, we need to think about reduction of disability as being one of the main things that we focus on when caring for these patients. And that's really one of the keys to resource utilization, because so much of this money, the median cost after discharge was $12,700 US, which is more than a heart failure admission. But then that's skewed the huge heterogeneity with massive cost users, the people that were home the least, obviously enormous cost users. So this is like how to help patients, and also how to have appropriate resource utilization is focus a lot on disability and getting people home. This is just stratified by revascularization strategy. So patients with CABG incurred the most resources. No revascularization was the least, probably because they also had the highest mortality in hospital. And then if you look over the past 10 years, there actually has been significant change in cost. So those are really the main research topics that I've been involved in, that I am excited about, that I want to share. There's lots that I really want to see and investigate in the future. And blood pressure targets interest me a lot. Levosimendan hopefully will come to Canada, and it can be used in research, and we can see it. If DORIMI2 is negative and dobutamine and milrinone don't seem to improve outcomes, levosimendan is a completely different drug. Early renal replacement therapy is another really interesting question, because all we need to do, in my opinion, as someone with not a lot of experience, just still a trainee, what I seem to see is that you just need to decongest these people as quickly as possible. That's kind of how you get them through the shock cycle. And if they're not peeing with Lasix, instead of waiting for days for them to finally go on dialysis, do you just start the renal replacement therapy right away? That's another really interesting question. So there's tons of things to look at that I'm excited to hopefully participate in the future. My personal career plan, Dr. Connolly mentioned, I'm going to be doing kind of a mini ECMO fellowship in London for the last 6 months of my 2-year ICU fellowship that I'm doing right now. I'm doing my master's, and hopefully eventually going to do a combination of clinical cardiac intensive care and research in this specific field. These are some of the collaborators that really have mentored me a lot, and that their names are on all these papers. But Ben Hibbert is a structural interventionalist that now works at the Mayo Clinic. She was my research mentor during my cardiology fellowship. Rebecca Matthews, the head of the cardiac ICU in Ottawa, she's been a close mentor to me as well. Pietro is an intensivist and interventionalist now at the Heart Institute. And then Shannon Fernando is a big critical care researcher in Oshawa, who's another research mentor of mine. So those are the references from this talk, and I'm happy to answer any questions that anyone has.